Thank you, Farah. Now, the first thing that I need to say is that children definitely are not little adults. And one of the big problems that we have with research in children is not so easy to do as in adults. So we usually have a lag with data, and we have fewer studies in children. But I'm going to try my best to give you some practical guidelines of what we could do. But I'm going to first look at acute kidney injury in children, because I think it's often a big headache for dietitians when they are working in a pediatric ICU. What do we do with them? And the end result of acute kidney injury might be that you end with a child with chronic kidney disease. So they interlink, and that's why I'm going to start with chronic kidney, acute kidney disease. The objectives will then be to understand terminology, because we need to know that there are certain terminologies that's a little bit different in children. We look at acute kidney injury, the diagnostic criteria, the definition, the causes of acute kidney injury, and the nutritional challenges, where I hope to give you some practical guidelines how we can meet these challenges. Just to understand terminology, where in the old days we spoke about acute kidney failure, the terminology nowadays is acute kidney injury. We use kidney disease instead of renal failure throughout, as Arina has also shown you. Renal osteodystrophy is now part of the chronic kidney disease metabolic bone disease, and diabetic nephropathy is now being considered diabetic kidney disease. Organizations, just to familiarize you with them, they are there. I'm not going to go into detail, so let's go into acute kidney injury in children. What are the diagnostic criteria and definitions? Because how do we know that the child that we're dealing with actually do have definitions? Now, there's different systems. I'm going to discuss the first one with you. The rest is in your slides. P-Rifle, set up in 2007, where changes of kidney disease are estimated by kidney function are estimated with creatinine clearance. The R is that the patient is at risk of developing acute kidney injury. In I, there is already an injury. The F is the failure. Then at the L is the loss of kidney function, and the E is the end-stage kidney disease, although they still call it end-stage renal disease. And these are just the different diagnostic criteria. When the clearance decreased by 25% with some urine output, and eventually you have your end-stage kidney disease as persistent for 3 months. There is the Akin system, where you have the 3 stages. Then I've given you the data, you can have a look at that. There is also the Digostone system for pediatrics, where they use the serum creatinine level and or the urine output. Again, 3 stages, and again similar, where they look either at the increase in percentage, or in this case, they look at the baseline and how much it has increased. So what are the causes now? Where previously we thought that the underlying cause was a primary kidney disease, in other words, a child born with some form of kidney disease, it's now there's a shift in epidemiology. And similar to in adults, the kidney hyperperfusion is now the most common cause of acute kidney injury in children, especially after heart surgery, severe sepsis, children who had severe burns, and even in drug nephrotoxicity. The challenges, your critically ill patient admitted to ICU is often in a poor nutritional state. We found that 20% of children might already be malnourished when they're admitted. There are many factors in the critical illness that worsen nutritional status, and we're very familiar with them. Catabolism, increased nutrient requirements, and immobilization contributes to these. And underfeeding is the other problem that we then face in an ICU. Any of you who work in an ICU, whether it's an adult or a pediatric ICU, is the difficulty to reach our requirements due to inadequate prescriptions, incorrect estimations of the requirements, or a delay in nutrition support. And in children, you will see that plays a huge role. And also lack of awareness of the importance of early enteral or early nutrition in your critically ill child. And this ends up with a progressive protein energy deficit in children, which can have severe outcome, and we will look at those. Malnutrition in this setting will lead to increased mortality, and Irina has showed you a lot of data, and in children it's no different. There are also more frequent complications, longer stay, higher cost, but then a very important part in children that's different from adults is that they have impaired growth potential. Because we have to remember we're dealing with children who still are growing and who need to reach their potential. Because not reaching their potential has a huge impact on their quality of life later on. This is a recent study that was published on the 13th of May. It's online. It's not yet published in the journal itself. But this was they looked at the adequate enteral protein intake in children, critically ill children, not specifically kidney disease or acute kidney injury, but just looking at what is the impact of getting enough protein into your patient. This is specifically children. And they actually looked at 1,200 children requiring mechanical ventilation out of 59 PICUs in 15 countries, so it's a huge study, and 985 of them were on enteral nutrition. Just to point out, the sickest of the sick were the ones who were suffering the most. The morbidity of the patients with very low protein intake, where the adequacy is actually below 20%, there was a 21% probability that or increased 60-day mortality. So that just shows you how important protein intake it is and what are we going to do to reach our. And their conclusion was then that delivery of more than 60% of the prescribed protein intake is associated with lower odds of mortality in mechanically ventilated children. Now think about our acute kidney injury. They already have problems with their kidneys, so what are we going to do with them? 80% of children with cardiorespiratory failure may suffer from acute kidney injury, and they are at high risk of malnutrition because of the hypercatabolism, hyperalbuminemia, the loss of the lean body mass, because of all the different reasons why this is happening that I'm not going to go into detail. What we actually need to remember with children is that they don't have the same stores as we as adults, and they quickly lose especially their muscle tissue as well as adipose tissues. In a study by Cahill et al., they looked at the adequacy of nutrition support during the first 5 days in the ICU, the pediatric ICU. Out of the 167 children, 44 had some form of acute kidney injury on the whole spectrum. And they looked at the actual energy and protein intake during the first 5 days. They defined optimal feeding is that they must meet 90% of the prescription, but because children have a high intrinsic anabolic drive and they have no nutrient reserves. But look what they found. Less than 68% receive of the energy supply, and less than 35% of the protein needs supply, which is actually shocking. This is the leading to protein energy debt that contributes severely to the protein energy wasting in our patients with kidney disease. And this is impossible to catch up during the hospital stay. Even should they pass through acute kidney injury and recuperate, to catch up that loss or the deficit is virtually impossible. And they might end up with severe acute malnutrition in about 33% of our pediatric population. And 25% might end up with chronic malnutrition or growth stunting. What are the causes of this underfeeding? They are often seen as medical unstable. There's food restrictions, and we know the difficulties that we have when there's not enough food for us to provide nutrition. Electrolyte imbalances, GI intolerance, and interruption of feeding. There's one study that I haven't included here where they've looked at just the interruption of feeding, where patients were not fed for up to 8 hours per day. So how do you catch up with all of that, especially in children? And then often, especially it was in adults, but now even more so in children, the doctors think they should restrict the protein, because then they don't have to start renal replacement therapy rather sooner than later. But it's now been proven that it's better to start earlier, because then you have a better outcome, because then you can give your protein, you can get closer to the targets that you have, that you need. And often the fluid issue is then null and void. So in conclusion, underfeeding is accentuated in your acute kidney injury in children, and adequate nutrition support is needed to improve outcomes. So acute kidney injury plus your protein, energy, malnutrition then leads to increased morbidity, mortality, and poor growth. And as we said in the beginning, they are at high risk of developing chronic kidney disease. So the protein energy wasting, I'm not going to go into it in too much detail because Arina has spoke about it in length. This is just the definition. This is just a slide to show you that what is the impact on the child, because now all of this, she's discussed it in detail, but the end result in the child is that it leads to growth failure. All the causes, it's all listed there, but you end up with growth failure. So how are we going to meet the challenges then for the child with acute kidney injuries? First, we need to decide what our goals are. Of course, we would want to control the symptoms of uremia, we want to preserve the residual kidney dysfunction, and we want to prevent protein energy wasting if we can at all, and preserve lean body mass and nutritional status. And least but not last, but the very important one, we would like to promote optimal growth. Because even during acute kidney injury, the growth can be impaired, even if they do not continue on to chronic kidney disease. And then to prevent complications, the wound healing and the immune function, as we were all very familiar. But to calculate a nutrition prescription, we first have to do an assessment. And Rogers said in 2006 that adequate nutrition assessment is paramount for the decision-making process of nutrition intervention. But we have challenges in assessment. Who of you have proper weights in an ICU? We don't have it. And most of our calculations are weight-based. But we don't have the weights available. Anthropometry is time-consuming, and bioimpedance might be a useful tool, but we don't have that available. Biochemical indicators are often influenced by fluid status. So what are the challenges in our nutrition prescription then? We have to consider the underlying disease. We have to look at the prior nutritional status, the presence of complications. Is the patient being sedated and ventilated, because that will have an impact on energy requirements? And is this patient on renal replacement therapy? And depending on the type of therapy, that will also change our requiremms. But there's an imprecise determination of the needs. So we might end up with either underfeeding or overfeeding, which is another problem. The very ideal would be to do indirect calorimetry, but any one of you here doing that? I know we have a metabolic card in the department of human nutrition, so that the students can just see what it looks like, that they know about it. But to look at, I will point to it later, tell you about it later again, but in Europe they found that only about 17% of pediatric ICUs do use indirect calorimetry. Now, what are the recommendations then? For protein, we want to give sufficient blood skeletal muscle wasting. We want to give the amino acids for the acute phase response, and we want to replace all the losses with CRRT and SLED. And SLED is sustained low efficiency dialysis, for those of you who are not familiar with the terminology. I haven't seen it used in South Africa, but where I've been before, it was being used. And so, on the other hand, we don't want to give too much protein, because then we end up with maybe uremic toxins. And we have to remember that high biological value proteins, or animal proteins, can contribute to metabolic acidosis because of the renal acid load. So there are different recommendations. One of them is aspirin. And we might need to add additional for renal replacement therapy, but these recommendations still have to be validated in the pediatric population. There's another group, the British Medical Journal group, who also have made some recommendations that you can look at. It's as little, as much as 3 to 4 grams per kilogram in preterm children or babies then, on peritoneal dialysis, and in the almost adult child it can be as little as 1.5 grams per kilogram per day. Energy, the gold standard, as we've said before, is actually the actual energy consumption measured by indirect calorimetry. And it measures the resting energy expenditure, and this will help us to avoid under and overfeeding if we were able to do it. But it's very seldom used, and as I said in the European study, of 111 PICUs, only 17% use this. The validated energy equations that we have frequently over and underestimate the energy requirements. Sean Lawson made some requirements, but basically it comes to we're giving you the DRI, and then follow-up becomes very important in these children. The energy sources should be carbohydrates and lipids, not only one, because we want to limit the use of amino acids for gluconeogenesis, preserve the lean body mass, and decrease negative nitrogen balance. Because remember, we want them to grow. Just a word about blood glucose control in children. We aim for about 8 to 10 millimoles per liter. Any more aggressive control poses a huge risk for hypoglycemia because we don't monitor continuously, and the impact of hypoglycemia on children can be fatal. Fats, lipid oxidation is increased in the critically ill children, and fatty acids, as we know, is a key energy substrate. And then, therefore, they must be included in the macronutrient mix, also to prevent fatty acid deficiency. But remember, children, normal children, I'm not talking about the obese group, they're a totally different group. They have a limited fat stores. In parental nutrition, it's recommended that we give up to 40% of total energy as fat. So the nutrition support are often needed to meet requirements. It might need enteral or parental nutrition support, and early introduction of your renal replacement therapy will assist in tuning our goals then sooner rather than later. This is just a nice algorithm that I've included from the Pediatric Nutrition in Practice textbook by Kuletsko is the editor, just to help you in practice. Basically what it means is that you start on the first day just with the carbohydrate and then progress on a daily basis depending on your renal function. But what more can we as dietitians do? First off, we need to raise awareness of the problem of protein energy debt in critically ill children, all critically ill children, including our acute kidney injury, and its role in the pathogenitis of protein energy wasting and impaired growth. And of course, if we could do some more research, that would be a great help. Now we're going to move to chronic kidney disease. I have included in your slides most of the age groups, and if the time catches me, I will probably skip over because I would really want to get to a very special group at the end, and that's the infants. But let's then start. Definition is abnormalities of kidney structure or function that's present for more than 3 months with implications for health. And this is just the GFR. But what is important that you have to remember is that for children, it's only valid after the age of 2 years, because up to that stage, the kidney are still in development. This is just the staging of kidney disease with most severe symptoms in end-stage kidney disease. And nowadays we also consider albumin, the excretion of albumin to determine the risk of especially things like cardiovascular disease and later on morbidity. So what are the causes and the incidence and prevalence of chronic kidney disease in children, we've seen that there's a huge increase in the whole world. Now, again, there are not a lot of data for children, but the United States do have a registry since 1994, and they have data on more than 7,000 children, and it's very interesting. They consider you below 21, you're still a child. And they found that congenital causes are the most common cause for chronic kidney disease, but that the older the patient is, the proportion of acquired diseases increase, of course, progressively with age. In Europe, it's similar. In a group of 143 Belgian children with CKD, they found that almost 59% also due to congenital problems. But in places like the Middle East, you have a high proportion of genetic diseases due to the high level of consanguinity is still around there. And what about sub-Saharan Africa? We see that chronic glomerulonephritis, including nephrotic syndrome, is the biggest cause. And it's expected or considered the cause of it is because of the high prevalence of infections that affect the kidney. But there is the question about HIV. What is the impact of HIV in children on kidney disease? There's limited data for the early stages of CKD. If you go and try and find data, you would see that it's mostly related to end-stage kidney disease because it's often asymptomatic and underdiagnosed. In Europe, the incidence is about 11 to 12 per million age-related population. The prevalence 55 to 75, and very interesting, a predominance in the male gender. They don't say why. In sub-Saharan Africa, we have very little data. Nigeria says that they have an incidence of 3 PMRARP. What prevalence is, nobody knows. In South Africa, the similar. We don't have a registry, we don't know what the situation is for children in South Africa. The progression of kidney disease in children are dependent on two groups of factors. The one part is non-modifiable, the other part is for sure modifiable. The non-modifiable factors are those that like congenital disorders. They usually show a slower progression, the genetic predisposition, and low birth weight. Because low birth weight, you have fewer nephrons that predispose you to hypertension. And the rate of progression is greater during puberty because they have a higher blood pressure. There's an imbalance of residual nephrons and a higher demand, and also the altered endocrine physiology during puberty. Modifiable factors, and that's where we as dietitians definitely can play a role. Hypertension and proteinuria. It's found that about 50% of children with chronic kidney disease actually have hypertension, but often it's masked that they don't know. The ESCAPE trial looked at hypertension, and they found that if they could control the blood pressure of children below the 50th percentile age-related hypertension, blood pressure, it slowed the CKD progression during the 5 years follow-up. Obesity, because now we see that there are also now obese children in our populations. What we know is that it has a similar effect as on adults, but there are large studies on lacking. We don't know yet the outcome in children. Pediatric chronic kidney disease and end-stage kidney disease is a small portion of the actual number of people who have either CKD or end-stage kidney disease. But the problem is that they pose unique challenges because we must address the primary kidney disease, but also all the extrarenal factors that affect growth and development. The etiology of the growth impairment then, what is causing this? There are many causes: the age of onset, inadequate nutrition, metabolic acidosis, anemia, polyuria, and salt wasting for metabolic bone disease and bone maturation, and the resistance to hormones mediating growth. And I'm not going to go into all of them, but we will look at some of them. The first one is the age of onset, of course. 1/3 of your growth happens before the age of 2 years. So the younger you are, or the child is, the higher the chance of growth impairment. Infants with CKD are at severe risk of growth retardation, and they may result in irreversible loss of growth potential. The North American Pediatric Renal Transplant Cooperative Study has a CKD registry, and on enrollment they have found that in the age group 0 to 1 year, the disease score for height was below -1.88. That's what they considered as stunting. It's about 58%, where if you were older than 12 years, the chances of being stunted was about 22%. So inadequate nutrition, anorexia, recurrent vomiting. They have a tendency to have gastroesophageal reflux. Peritoneal dialysis can cause increased abdominal pressure and they don't want to eat. Polyuria. If they have polyuria, they often choose to drink water instead of eating to satisfy their thirst. They have reduced taste sensation, reduced appetite. There are times that they have to fast for procedures, episodes of infections, and poor compliance to the renal diet. The other one of the others, metabolic acidosis. The severity of acidosis is aggravated by protein and acid load, metabolism, and renal tubular dysfunction, and this impairs your growth hormone secretion, and we need that for growth. The bone disease and bone maturation, Irina went into a lot of detail, but the dysfunctional vitamin D metabolism, secondary hyperparathyroidism, and the role of phosphate in the diet all contributes to this. There are other challenges: hypertension, cardiovascular disease, the role of obesity and malnutrition. So we have a dichotomy. Urbanization, that's changing the eating habits of populations. And then HIV nephropathy, as I've mentioned before, but we don't actually have data for that. So hypertension, the CKIT Professor Co study that's still ongoing, but they keep on publishing data. In this case, they followed 568 children from the age of 1 to 16 years until the age of 21 years, and they found that they had either 54% of them had baseline or systolic hypertension. And the most worrying one is the masked hypertension, where it's not actually recognized. And they diagnose these children by putting them on a 24-hour monitor to see what their blood pressures were during that period of time. So strict blood pressure control is warranted, and it has been shown that it will improve survival of your kidney patients. And then cardiovascular disease. As in adults, in children, this is the leading cause of death in chronic kidney disease. And again, this KID study has found that 45% of them had dyslipidemia. These are children, we're not talking about adults, so that is actually frightening. Obesity, another challenge. It's a dichotomy of obesity and malnutrition. We know that obesity has a role in, it's a risk factor in cardiovascular disease, that have higher triglycerides, and probably because of urbanization and the change of eating habits. It's very interesting, just before we were standing outside, and it was very interesting to see what the students were walking past with their food. Very high in phosphates, very high in carbohydrates, and bad fats. And children are no different from our students. So obesity, hypertension, dyslipidemia all contribute to the cardiovascular disease in chronic kidney disease. And then there are other challenges, especially for us in sub-Saharan Africa, where there is a suspected HIV-associated nephropathy in children, but it's underreported. And the incidents are unknown, but expected to contribute to the burden of disease in Africa should we have the data. The guidelines meeting the nutritional challenges, I'm not going to go through all of them, just to say that DOKI has made some recommendations, but as with many of the things, there are limitations in all the assessment tools that we use. Because many of them are related to weight. We don't have weights. There are no consensus guidelines for nutrition assessment in children with CKD, but we should not ignore assessment. It's very important, because how are we going to know if the child is actually growing and progressing as we would like them? Because accurate growth and nutritional status assessment is central to the management of the children. But we have to understand the limitations of those tools that we actually do use. Regular assessment and follow-up by a renal dietitian is crucial, and they've actually found that it should be around 6 contacts per month for a child on peritoneal dialysis who are less than 5 years of age. I don't know where they get all the pediatric the renal dietitians. And then 3 contacts if you're older than 5 years, in order to prevent malnutrition, in preference to treating it once it has developed. So the whole aim should be that we try to prevent malnutrition from happening and not wait until it has happened. Psychosocial problems related to the non-adherence to diet is similar to in many others, especially when you're dealing with your children and your young adults. First thing is they cannot eat the same foods, or we teach them that they should not eat the same foods as their peers. But of course they will eat the same food as their peers, because otherwise they feel isolated and they might exhibit maladaptive behavior. Depression is a common problem under this stage group. Low socioeconomic status will play a role in adherence to the diet. And a study has found that even mild to moderate chronic kidney disease will lead to short stature and a negative impact on quality of life and even school function problems. So it is very important that we catch these children at an early stage and try to deal with it. The thing with children is that one diet do not fit all, because there are different. So there are different guidelines. The DOKI guidelines is the latest that we have for children. We don't have new guidelines for children. The energy, basically the energy and the protein is that we use DRI, and that we work according to that. And then we have to monitor weight gain for loss or losses and adjust accordingly. How can we then increase energy intake, such as some ideas? I think Cecile will give us a little bit more practical ideas. But oil and margarine to pasta, rice, noodles and other staple foods, glucose polymers or even sugar or honey, child-friendly snacks. Now here you have to know your population to know what are their snacks, but these are just some that we used to give successfully: shortbread biscuits, pink wafer biscuits, not the cocoa one, the chocolate one, because it contains too many phosphates, sweetened popcorn and marshmallows. When I was a young dietitian, marshmallow was the thing that I really liked to give to my patients, because at least they could have that. When we told other people, other children, they're not allowed to eat sweets, we tell them, just eat as many as possible that we can get some extra energy into you. But ultimately, we still have to provide balanced macronutrients to prevent cardiovascular disease, and we have to look at the type of fats that we use, and the recommended acceptable macronutrient distribution is then provided to you. Protein, 100 to 140, or depending on the stage, down to 100% of the daily recommended intake, with some adjustments for hemodialysis and peritoneal dialysis. The adjustment for hemodialysis is not as high as we previously thought, because of the better modalities of dialysis that we have nowadays. It's now been proven that only 0.1 grams per kilogram per day is sufficient, if we can get that into the patient. That is always the big problem, because how are we going to meet this? The first thing is we have to know what the protein sources in the community is, or are. Things like minced or chopped meat, chicken, egg, tofu, or even skim milk powder, but remember phosphate and the sodium. And ultimately, we might have to give a supplement, but is that always available? And also then we have to bear in mind that animal proteins has a higher potential renal acid load that can worsen metabolic acidosis and impair growth. Here we come back to the phosphates, that proteins are high in phosphate, and cardiovascular morbidity that goes with it. And Arina has discussed this. This is just another table, and another way of expressing it to you is that looking at the protein, the phosphorus-protein ratio. Something like a large egg white is 1.4 milligrams per gram of protein, where a cup of milk you have 28.3 milligrams of phosphate for every gram. So that's every milliliter of milk that you give. That's quite high. And if in a child, if you only have a limited amount of phosphate to allow, that is a big problem. Phosphorus always have to be considered with calcium and vitamin D status. In children, we will have a moderate restriction to prevent hyperparathyroidism, but because over-restriction may lead to deficiency in children, which will then impair your growth. Remember that most of the phosphate binders that we use in South Africa are calcium-based, and the timing of that is very, very important. Don't let the doctors prescribe it 3 times a day, and then you get to the ward and it was giving 6 o'clock in the morning, 2 o'clock in the afternoon, 10 o'clock at night. Then it doesn't work. Then you end up with a patient with excessive amounts of calcium. You want to give it with meal times so that the calcium and the phosphate can bind. I'm going to skip all the next because I see I've got 2 minutes left. All the practical and things like the cola drinks that Arina has spoken about, the timing of phosphate binders, all of this is in your slides. Because I want to get to our infants, because there are some practical guidelines there that I would really like you to use, to be able and to be aware of. This is just a guideline of how you can structure your diet for children. 5 portions of fruit and vegetable. Of course, you're going to look at the lower potassium, if the potassium is a problem. Only 2 measured portions of protein, 2 measured portions of dairy, and 5 portions of cereals or starchy food. But remember, you have then to teach your patient about portion sizes and cooking methods. Our special groups are the infants with CKD. A child or infant with CKD is usually being targeted for kidney transplant as the treatment. And they have to be 10 kilograms before they would consider them for kidney transplant. So what are you going to do in the meantime? Because you want them to grow. There are many feeding problems, and you will then have to work with a multidisciplinary team to enhance oral intake, because remember, with infants, you still want them to develop as children. So they need to get used to how do we eat, how do we chew, things like that. And eventually you would like them, because many of them end up being dependent on tube feeding or enteral nutrition support during the time prior to transplant, but once they're post-transplant, they are supposed to be like normal children, and they have to be able to eat, and it might take up to 2 months and longer for them to actually develop all their normal eating habits. So for all the factors, we've already discussed those. And as we've said, they still need to establish normal eating habits. So, and what can we give? Breastfeeding, and because it has a low amino solid load, the same as and then you can start with weaning foods at the age of 6 months. Very important not to force feed, because then you will cause very bad eating habits in your children. This is the part that I really want you to know about, and this is what we do with hyperkalemia in our infants. Because we cannot give KXLA to our children, because they will develop gut necrosis. They might have excessive stooling due to the sorbitol content of the diluent, and they also develop hypernatremia, because remember, KXLA is an exchange potassium for sodium. So how do we do it? The procedure is there. Basically what we do is we get either the express breast milk or the infant formula. You treat it with KXLA, and I've given you all the information there, how much to give. And then you let it stand for at least 2 hours, of course preferably in the fridge. And then you decant and you give that milk, so potassium has been absorbed out of that, hopefully. Tube feeding is then often, as we said, needed for these children to actually grow. But remember that we need to continue oral stimulation during this time, and start then when your child or the infant is ready to start with food, the actual food. The novel therapies, all the things that's been done for adults, we hope that that will contribute to treatment in children also at a later stage. But there's few studies in adults, but there's no studies in children yet. But hopefully it will help them to develop their potential. These are just the same as the sucrolytic and the proteolytic fermentation. So in conclusion, we have to remember that children are not small adults, and as such pose unique nutritional challenges. Optimal growth and neurodevelopment at a young age are vital to reach our full potential as adults. And children with kidney disease are at high risk of growth impairment and all its consequences in adulthood. And I haven't even spoken in detail about the psychological impact of being short and stunted. Early recognition of kidney disease is important to achieve the best outcomes, but again, as I stated before, the data for sub-Saharan Africa is lacking. And it places a responsibility on all of us, as healthcare professionals, to collect data and do research. But that should not stop us from meeting the nutritional challenges with the knowledge and the tools that we have available to improve outcomes and the quality of life of children with kidney disease. I thank you for the time.